Okay, well, greetings and welcome to session 2 of the Lurie Children's Pediatric Surgery Roundtable Series. In this session, we will introduce you to pediatric surgeon, Dr. Guillermo and our APRN, Elissa Williams. They will be introducing you to the Lurie Children's Adolescent Bariatric Surgery Program and discussing the topic of adolescent bariatric surgery and who benefits. My name is Chad Worley. I'm your physician liaison for the city North and Northwest suburbs. I am joined here by my colleagues Paula Nowak and Julie Kalkbrenner. Dr. Guillermo Aries is a pediatric surgeon. He co-manages a specialized multidisciplinary bariatric surgery program for adolescents with obesity and a range of obesity-related related issues. The first MBSA QIP accredited adolescent bariatric program in Illinois. The program offers progressive structuring for habit formation leading to healthier lifestyles, incorporating surgical intervention in the toolkit for weight loss and subsequent long-term follow-up. And Elissa Williams, an advanced practice nurse specializing in the care of treatment of children undergoing surgery for a variety of acute and chronic conditions. She currently provides services in surgical and non-surgical patients in the inpatient outpatient program and is a part of the Lurie Children's Adolescent Bariatric Surgery team, which they will both tell you about the whole program and all the team members for that later on in the program. For all of our providers online, I want to remind you that our referral toolkit will be coming out in May. You should be receiving them in your office. If you don't receive them or like to receive extras, please contact your liaison and we will make sure we get them to you. And I'd like to remind you that all the toolkit information is also available right at your fingertips online at the Lurie Children's Physician Services website. And on that site, we have all the patient referral information, outpatient provider schedules, contact resources, pediatric specialties by locations, and of course, our virtual program library, such as this one you're seeing here today. So before I turn it over to our presenters, I'd like to remind you that we are recording these sessions. And when it's done, we'll be sharing a link with you along with your colleagues who couldn't attend today. We do encourage engagement today. These are great. This is a great topic. I know a lot of you have been asking us about the bariatric program here at Lurie. So please type in your questions in the Q&A section. However, we're going to wait till the end of the presentation to answer the questions. And since our audience is pretty large today, we will not be unmuting anybody to ask any live questions. So without further ado, I'd like to hand it over to Elissa and Dr. Aries. And I'm going to stop sharing now, folks, and then you guys can take the screen over. And welcome to the program.
Good afternoon, everyone, and thank you for being here. Can you see my slides, Chad?
We do. And now we're in presentation mode, so perfect. Thank you.
Great. Well, thank you all for having us. I'm Guillermo, and this is Elissa, and we hope to give you a brief taste of what our program is like and answer any questions you may have.
Sure. Okay, so some of the objectives that we have today, we're going to briefly review the two Lurie Children's Adolescent Bariatric programs, one in Central Dupage Hospital and one at the downtown location. We're going to discuss the role of surgery as a treatment option for pediatric obesity and list indications and contraindications for surgery, and then review important considerations, including our multidisciplinary team approach, and assess for benefits and risks of surgery. Let's click it. Just a brief slide on Lurie Children's pediatric surgery commitment to patient care. We give expert, compassionate, and timely care close to home without barriers to access. We have available appointments same day or next day. We give general care at sites throughout the city and suburbs. And in each of those areas of subspecialty practice, there are different options available. All the stars indicate where pediatric surgery goes. And then more specifically, we have our bariatric surgery sites in Winfield and at the downtown location. In brief, this is our bariatric surgery team. Dr. Inge is a surgeon that primarily goes to the downtown location. And as you see here, Dr. Aris primarily works out of the Central Dupage location, though they do work together at both sites. Dr. Mangarelli is our medical specialist who primarily works downtown, and I am the nurse practitioner in the program, and I work at both sites. Here's a broader spectrum of all of our team members that work at both sites. Most of these specialists do see each patient at each visit that they have every month. And so diving into the why of bariatric surgery. So as we know, obesity is a serious chronic disease that affects the majority of the body systems, including the mental health and quality of life perspective of millions of children and adolescents. Increased obesity-related comorbid conditions are being seen at much younger ages. And bariatric surgery is currently the most effective durable treatment for severe obesity in terms of excess weight loss. Performing surgery during adolescence will likely have a much more profound effect on the psychosocial trajectory of patients, as well as prevention and amelioration of associated chronic diseases and mortality. Outcomes from surgery in terms of amount of excess weight loss, as well as resolution of comorbidities, is better with patients treated at a lower BMI and less years of disease. The AAP changed their clinical practice guidelines, as most of you know, in 2023 around the topic of obesity. And part of those things that changed was the inclusion criteria for bariatric surgery. So for class 2 obesity, which is considered with a BMI of greater than or equal to 35 or 120% of the 95th percentile for age and sex, with that, the comorbid conditions that we typically see that would be included are things like type 2 diabetes, NASH, SCFE, hypertension, hyperlipidemia, and any other health-related comorbid conditions. For class 3 obesity, the inclusion criteria is a BMI of greater than or equal to 40 or 140% of the 95th percentile. The comorbid conditions required for that, I guess they're not required, but they typically do have them at that BMI. The key action statement 13 that's listed talks about the referral process. So the pediatricians or other primary health providers should offer referral for adolescents 13 years of age or older for severe obesity for the evaluation of metabolic and bariatric surgery.
I would say of this is the inclusion criteria that we use broadly for our patients, but there has been consensus statements by the metabolic surgical societies and AAP that maybe we should even be considering starting our surgical care in even lower BMIs. And so this is a area of ongoing research and hopefully future changes that will allow us to treat patients sooner before their BMIs are, too high.
Some of the exclusion criteria include those who have medically correctable causes of obesity, like an leptin deficiency, ongoing substance abuse problem within the preceding 1 year. And just a note on that, a number of our patients do come to us with a history of substance abuse. And so, that's where the multidisciplinary team approach, working with our psychologist on board, we come together and we try to put a plan in place, and we try to get our patients into treatment or ensure that they are currently working with a treatment center therapist, because we don't want to totally exclude patients with a history of substance abuse. And then other exclusionary criteria would be determined by medical, psychiatric, psychosocial, or cognitive problems that would have adherence issues or compliance issues with our dietary and medication protocols. And then current or planned pregnancy within 12 to 18 months of the procedure. It's determined that it's not medically safe for our patients to get pregnant within 2 years postoperatively. Did I skip through? Aha. Okay. Big changes to our guideline. There's no lower minimum age limit for surgery. And while there is no minimum age limit, we do find that our younger adolescents, our younger patients do have a harder time with compliance. So just a little bit of a note on that. There's more standardization of similar inclusion criteria like the adult side versus the prior inclusion criteria that was more conservative for the pediatric population in the past. And then considering our special populations with our patients with developmental disabilities on a case-by-case basis versus an automatic exclusion. And then the changes also include that the adolescent bariatric surgery is best done in a multidisciplinary center, which is how we practice here at Lurie. So our program is compliant with many insurance protocols. What we found is that the requirements from insurance are tricky and they're not consistent from insurer to insurer. So most insurers who cover bariatric surgery under 18 have very strict requirements, but they are variable. Some of the similarities that we abide by are that we ask our patients to have at least 6 consecutive calendar monthly visits of lifestyle management, and that is within our multidisciplinary program. So they would come to us once a month for at least 6 consecutive months. Although I will say that most patients take between 6 and 12 visits. There is a psychological assessment that's required as well, clearing them for surgery and for readiness for surgery. Dietary assessments by our registered dietitian. They meet with the patient at every visit. Proof of obesity for 2 years by the PCP prior to our program. And then we also ask for a letter of support from the PCP, not so much a clearance letter, but just a letter indicating that you are aware of surgery and that you support surgery and that this is best for the patient. And then preoperative assessment by the bariatric surgeon within the time frame that they're in our program. On our side of things, we also ask the patients to do this too, is to make sure that bariatric surgery is not an excluded benefit from the insurance plan. We have had this happen. And in those circumstances, some patients will opt during open enrollment to change insurances so they can get bariatric surgery. Some barriers that we face are family and societal bias around obesity and around surgery, and that's an ongoing issue. It can be a cultural issue as well. And then personal readiness and compliance. This is something that we reassess after every visit. We meet as a team and we discuss the patients at great length to determine whether they have shown through the program that they are ready to make these intensive lifestyle changes to make sure that they are successful in the program. Important considerations around bariatric surgery. Our patients are at higher risk of pregnancy than their peers postoperatively. With dramatic weight loss, you can have increased fertility and self-esteem. Some of our patients might engage in behaviors they weren't engaging in before. For insurance purposes, we do need to document a postoperative birth control plan. And on that note, oral contraceptives are not well metabolized after surgery. And so we do recommend a long-term birth control option. We like to recommend an IUD. There's also things like the Nexplanon or the vaginal ring. We do recommend that they meet with an adolescent medicine provider if this is something that they want to consider. Best surgical outcomes are adolescent patients with a starting BMI under 50. And realistic expectations around weight loss are that most patients will lose between 20 and 30% of their starting weight. And so, those with a lower BMI under 50 will have a better ending point. The risk for alcohol and substance use disorder can change. After surgery, It's known that our patients metabolize these substances differently, and it is something that we talk about with our teenagers. Mental health and quality of life can often improve postoperatively with weight loss, as many of our patients have sustained ongoing bullying and traumatic events around their weight. However, eating disorders and self-concept disorders can reoccur. As we all know, mental health is a very complex issue. And then making sure that, you know, insurance has ongoing coverage for postoperative care. It's very important that our patients continue postoperative care, as, you know, we need to keep track of their lifestyle habits. And then it is worth noting that up to 20% of our patients don't lose the expected amount of weight, or they regain a considerable amount, and they are considered non-responders. And just a little bit more on realistic expectations. So bariatric surgery is the most successful treatment for severe obesity, but obesity is a chronic disease. So it is not a quick fix, it is not a cure, it is hard work, and it requires some significant lifestyle modifications. As I discussed previously, it takes on average between 7 and 10 months from the start of our program to when surgery is scheduled. We may have to submit to insurance multiple times, including appeals. Some insurances are getting better at approving bariatric surgery, but there is a longstanding history of some insurances that like to deny just to deny. So we will support the patient, we will appeal if we have to, but you know, we do also make it very known to the family that it is a possibility of this getting denied. Our standard of care within Lurie is to have multidisciplinary pre-surgical optimization to ensure safety and good outcomes. And that's why we have such a strong multidisciplinary program, is to make sure that our patients are set and ready and have made sustainable changes prior to surgery to give them the best chance at successful outcomes. And like I said, the post-operative follow-up is just as important to avoid complications and to improve outcomes down the line.
So I wanted to go a little bit into the data and the surgical process that we undertake, just to clarify what it is we do, and then leave some time for questions. There are two commonly performed bariatric procedures in the year 2023, and that's the sleeve gastrectomy on the right and the Roux-en-Y gastric bypass on the left. You may have heard of a gastric band. That is by far a thing of the past, and other approaches too. These are by far the most commonly performed procedures. About 95% of our patients will undergo a sleeve gastrectomy, but they may be preemptively familiar with the bypass because maybe somebody in the family had a bypass before. The bypass surgery has been around for longer, so it's a more commonly known procedure. The key differences is that for a sleeve gastrectomy, we essentially just resect the greater curvature of the stomach and just leave a small sleeve or conduit of stomach left behind. So in that sense, it is mostly a restrictive operation, but there are also metabolic changes that go along with it, and hormonal changes. The Roux-en-Y gastric bypass also contains a gastric resection, so a larger portion of the stomach is removed or disconnected from the continuity of the enteric tract. And then there's a rearrangement of the small intestine anatomy so that a segment of the small intestine is bypassed, and the food that's ingested goes straight into the distal loop of the jejunum, and in that way causing a further restrictive and malabsorptive operation. Now, the reason we perform surgery is because there's been documented change significant percent change from the baseline after surgery, both with sleeve and bypass surgery. Okay, the sleeve gastrectomy has pretty similar outcomes, and we do anticipate to have about a 20 to 30% weight loss from the day of surgery with the sleeve, but the bypass having about 25 to 40% weight loss on average. So they have fairly comparable outcomes in terms of weight loss, and both of them lead to resolution or significant improvement in associated comorbidities that I'll get into in a minute. And that even includes kidney dysfunction, lipid dysfunction, hypertension, and diabetes. This graph is the data looking at diabetes as a comorbidity and as a function of BMI, with the blue being treatment with surgery and the red being optimal medical management. And so you can see on the left that with optimal medical management, we do see, since the study began, a slight uptrend to stabilization of the BMI. However, on the A1C percentage data on the right, even with optimal medical management and stabilization of the BMI, there's still an uptrend, a significant uptrend toward on the A1C with medical management. With bariatric surgery, you can see a significant drop in the BMI and then stabilization after a small increase. But the hemoglobin A1C percentage drop was sustained at a lower level and for much longer in the long-term follow-up data compared to medical management. Now, this may be subject to change in the coming years with new anti-diabetes medications, but we're far away from having long-term data there. And the other thing that I will note is that our starting BMI on the surgical population here is much higher. And so I do foresee that there's just as much benefit, if not better, for people who have a lower BMI undergoing surgery. This is a study looking at sleep apnea in 7 pediatric patients that underwent surgery. They all had documented obstructive sleep apnea with polysomnography, and they repeated their sleep study at 3 and a 5 week post-op. And you can see that even within that short-term interval from the time of surgery to the repeat sleep study, there's already a dramatic weight loss, and with that weight loss, there's associated resolution or improvement in their AHI index, which is the index of sleep apnea. And what we see in clinical practice in our patients after longer follow-up is that they're able to come off their CPAP and stay off of it long term. So we do see brisk resolution with sleep apnea early after surgery. We also see improvement in all categories of non-alcoholic fatty liver disease. This was a study that looked at 56 patients that were eligible for biopsy post-op, and half of them underwent a biopsy post-op. So we're looking at only those 23 patients. There were no difference clinically or demographically between those that were put in the group for biopsy post-op. But looking at the patients that had a liver biopsy initially and the 1 year after surgery repeat biopsy, there was dramatic improvement in all categories of non-alcoholic fatty liver disease. And in fact, resolution of those that had definite NASH. We don't see those on the post-op follow-ups. So this is a very encouraging finding just from the bariatric surgery standpoint. The next several slides are comparing adolescents versus adults in terms of bariatric surgery. And so we can see here, these were bypass patients, that the pediatric patient and the adult patients had similar weight loss from the initial operation and sustained weight loss after the 5-year follow-up. So similar outcomes compared to the adults. This is not from the published study. This is one of our internal data review slides that I wanted to add here. Looking at in the green, our facility, including adolescent and adult patients, and in the blue is just the adolescent patients. And we can see, again, this is for sleeves instead of bypasses, that we see a similar drop in weight in the initial year follow-up, and then sustained weight BMI loss over time. Our 4-year follow-up data here is very few patients. So as we get a bigger N here, I think we're going to have a better idea of how stable this weight loss is. But I will say that from this slide, we are getting our patients a higher BMI than the adults are. And I think this is one of the areas in which I'm encouraged by the changes in the AAP guidelines. If we get to these patients earlier, I do anticipate having better outcomes over time. Back to that published study, looking at adults and teens from bypass surgery, we do see that there's resolution of or remission of diabetes in the vast majority of patients, but in the teenage population, it's an even more dramatic effect compared to the adults. And the same trend is seen with management of hypertension. We can see hypertension remission in both pediatrics and adolescent and adult patients, but more so in the adolescent population. And what's encouraging about this, furthermore, is that not only is there remission now, they're going to have their diabetes and the hypertension managed well from age 20 as opposed to having, and you don't have all those added years of comorbidity on your shoulder, under your belt, compared to those who are having surgery at age 40 or 50. We do see a prevalence at 5-year post-op outcomes of nutritional deficiencies after all cancer bariatric surgeries, worse so in the sleeve, in the gastric bypass population compared to the sleeve. So this is something that we have to be mindful of and counsel our patients carefully about, and also monitor in our post-op follow-up. So this is why we keep a close eye on them to make sure that they're able to, that we're correcting their nutritional deficiencies and that they're engaging in the dietary habits that are also conducive to mitigating them. So in conclusion, we see that after bypass surgery and sleeve gastrectomy, teenagers are having significant improvement in their weight loss, in the weight and the BMIs, and improvement or even resolution of most of the comorbidities for a longer duration in their life. We see significant weight changes in even as early as 3 months after surgery. And so timing is everything, right? Like teenagers have, in general, better outcomes than the adults because they have a lower comorbidity complications after surgery, given their adolescent privilege. And this is something to consider, especially in family systems where you have pediatric patients and the parents who are all part of the obesity cycle. As surgery is not without risk. We have our standard risk after surgery plus the nutritional deficiency that we have to follow. And lastly, as Elissa mentioned, insurance for surgery and access to care has been changing. And this we anticipate seeing more changes in the positive direction in the future. And with that, I would like to open for any questions.
That was great. Thanks, you guys. Their questions are flying in, as we all knew they would, right? So let me just go ahead and start from the beginning here. So from Brooke Turnock, do you find that Medicaid plans cover bariatric surgery for patients under 18 years old?
Yes.
And they may be a little bit more strict on the adherence to guidelines, to the criteria that we mentioned earlier. But we apply those criteria to all of our patients, regardless of their insurer. So we are able to meet their criteria and get them through insurance after they complete their bariatric program requirements.
Mm-hmm. And then Christine Grunwald says, at this time, what percent of patients that are referred for evaluation for bariatric surgery end up going on to have the procedure done?
Most.
Yeah,
most.
The
Great.
majority do. And some may take a little longer, especially the ones on the younger end of the spectrum. We find that they take a little while longer to find motivation or settle in or understand the magnitude of the changes they have to make. But most of our patients are able to get through the program and undergo surgery. The ones that have had to pause the program have had other complications or comorbid conditions need to be addressed. But those are patients that we re-engage after they've been treated.
And even for some of our younger patients that might not be mature enough to handle the lifestyle changes that we're asking them, we don't want to drop them because we understand that it will be beneficial for them to have bariatric surgery. So sometimes what we do is keep like a periphery on them. And so we'll have them follow up every other month or every 3 months just to keep an eye on them and see if, they can handle some of these changes on their own before we re-engage them full-time in the program to get them ready for surgery.
Okay. And Brooke Turnock asks again, what is the general plan for post-op follow-up? Do patients continue to meet with the nutritionist, and how regularly do they do that?
Yeah, so that's a good question. So initially we follow them at a 2-week and 4-week post-op visit, and then every 3 months, just about until the year mark, and then annually after that. The dietitian does meet with them at every single appointment, both preoperatively and postoperatively. And we, do heavy education on diet staging and things like that.
Okay.
So we see them at frequent intervals, early post-op, and then we start spacing them out. But we still see them at yearly follow-up, up to 5 years plus after surgery.
Dr. Christine Duong, she has the same question I do actually. Just curious, how many of these surgeries do we do a year?
Since I started, we've been averaging about 2 to 3 a month.
Okay.
And we hope to keep up the pace. We have a bit of a wait list that we're trying to address as well. So as we're able to get the patients through, we're going to see more and more of them come. And if we can get more in, we'll do more surgeries per month.
Yeah, and just, a little note on that, we do have a wait list at both of our sites. And
You were
part of
taking the
that
words
is,
out of my mouth.
yeah, we do, part of that is because of scheduling difficulties, because we do have to see these patients every month in consecutive months for insurance approval. So we can't overstack because we need to have space for them in our templates, right? So, just from a businessy side of things, there's only so many that we can see at a time.
That being said, now that the Lurie program is officially open, and we're operating at both sites, we're hoping to get through a lot of these patients more expeditiously.
Okay. I'm going to get back to that in a minute with a couple questions regarding referrals and stuff. I'm going to ask a few questions more questions that came in here. So Dr. Fareed asked, is sleep apnea a comorbid condition in consideration for bariatric surgery?
Yes.
Well, that was simple.
Count it.
It's a big one, and most of our patients have it. It's rare if they don't, honestly.
Okay. Do patients have to be off alcohol forever? How confident are parents that patient will be compliant with alcohol or drug use? That's going to be a tough question, right?
Yeah, especially because we're dealing with adolescents. And so what we have been experiencing recently is that those adolescents who are on the launching pad to finish high school and go to college, and start to think about how their future life is going to be and what they want to experience in their life. So these are all discussions that we have pretty openly with the teens and with the parents, and to my own surprise, is pretty. It's all out in the open there, and in the way we talk about this thing. So. So it's an ongoing conversation, and it's a decision that they have to make. That being said, we're not saying that they have to be off alcohol forever, but we do counsel them into alcohol is metabolized differently in the body. Alcohol is empty calories, and that may be a contradictory to your plans for losing weight. So these are all the information that we provide our patients, and then they get to make a decision. And
we even go specifically into it. Beer is carbonated, and you can't have carbonated beverages after surgery. Not that there's not other options out there, but like Dr. Ayers was saying, we do have very open, frank conversations around these risky behaviors like alcohol, drug use, sex, things like that.
It reminds me of a point that was brought up in session 1 with Dr. Ravel, and a PCP noted that it's important to have not only a great relationship, parent-child relationship regarding these topics, but a family PCP relationship, so these things can are ongoing to make sure the wellness is going on. So having a relationship with your PCP and your patient, it's going to be really important to keep up with how we're monitoring alcohol and drug use with these patients. So.
Absolutely. We had a patient come to us. She's been post-op for how many years now? And she was featured in the article. And, she said too that, after she was 21, she went out with her boyfriend and went out to go get a cocktail, and realized that after one drink, it hit her so much harder, than it was hitting her boyfriend, for example. And so, these are things that the patients do have to be aware of.
You might have touched on this earlier in the presentation, I missed it, but Dr. Amin is asking, do you ever counsel really obese parents? Or if I may add to that, what's our cutoff age that we're doing for the adolescent bariatric surgeries?
So we're loosely cut off at age 18. If a new patient coming after age 18, we would probably refer to our adult program right here or downtown. People who've been with us and they turn 18, they get to stay with us. We don't just turn them away.
And some of it is insurance dependent too.
Mhm.
Yeah.
So.
But you're not offering advice to parents though who are.
And so I'm not operating on the parents. That's correct. And so it's most often we see the opposite. We see mom and dad, or mom had or dad had surgery, and so now they're coming in to bring their child to have surgery too. It's usually not the case that child is having surgery and now parents want surgery too. But that being said, we're open about the family system could benefit from these changes, not just the adolescents. And if anyone's interested, we do refer them to our adult partner.
Wonderful. Great answer. Yeah.
Something that we do counsel the family on is like all the dietary and exercise changes that we recommend. It's so much better for the patient compliance wise and adherence wise if it's a family system change. And so while they're making dietary changes, if there's not Cheetos in the pantry, for everybody, but our patient can't have it, it makes it a lot easier. So we do find, we've had families that come in where everyone is losing weight and they feel really good about that. So
yeah, the culture of a family, it's got to be really important to the change that the child's making. Yeah.
Absolutely.
So let's talk referrals real quick. How do you want us to tell our PCPs that we partner with in the community to refer into you all?
It's a really good question. So right now there is, this presentation is slightly premature to what we have available. So there is an Epic build going on for an Epic referral system. So stay tuned. They are in the testing phase of that. So that should be out momentarily to where you can actually refer to bariatrics to either program, either the Central Dupage program or the Lurie Downtown program. It's just taking longer than anticipated. So for right now, the contact screen should still be up. Is it up? Yeah, with our information. You can always reach out to me. My email is listed there. Right now, we're doing a lot of referrals by mouth, if you will. Families are also, Googling and finding our program coordinator's name, Cindy Long, and there, you can always reach out to her as well and get the patients on the wait list.
That's great.
But I'm happy to be a point person for you.
Wonderful. And there's a program coordinator as well, correct?
Yes. There's one downtown, Annette Ortiz, and then there's one at Central Dupage. Go back further, right here. So you have Annette Ortiz and Cindy Long. Those are their phone numbers. You can always reach out to them.
Okay.
But like I said, you can also email me too, and I'm happy to spearhead that and send you in the right direction.
Okay, great. And to all the people listening out there interested in the program, when I send out the recordings to you all and to your colleagues, we will be sure to have a contact number for the bariatric surgery program for you all to reference. So, but that looks like all of the questions have been asked. You have answered them all. You both have been wonderful. I want to thank all of our audience participants out there and thank you for joining us today. I hope you got a lot out of it. And I want to invite you all tomorrow morning at 7:30 a.m. for session 3. And we're going to introduce to you Dr. Seth Goldstein, APRN's Lurie Sands, and Susie Kujwa. And they will be discussing what is the latest in operative and non-operative management for chest wall deformities. So another really great session, and you get to learn about another one of our great Lurie Children's programs, which is chest wall deformities. So for any questions regarding Lurie Children's, please feel free to reach out to your liaison and we will help you. But until tomorrow morning, everybody have a great day.
Thank you.
Thank you.